Thank you. I'm really pleased to be here today to talk with you about some clinical strategies for the management of both drug-drug interactions and adherence challenges with long-acting antiretroviral therapy. These are my disclosures. So as we know, we're really on a exciting trajectory to have a lot of new exciting delivery techniques for antiretroviral therapy. And these are just some examples of all of the work that the potential opportunities for long-acting therapies. My talk today is going to focus on long-acting injectable therapy, since we expect that to be our first available long-acting product. And then I'll use some examples from other disease states with other delivery techniques to help inform how we understand some of the challenges related to adherence and DDIs. So I'll start with adherence. I'm taking an example from contraception. So contraception is probably a condition that we have the most different types of products to deliver effective hormonal therapy. So this graph that I'm showing you describes the difference between perfect use of either a pill, an injection, or an implant. So if you use a drug perfectly, you would expect that all of these products will have similar effectiveness at preventing pregnancy. But then we have typical use, which is really more the real world, what you would actually expect to happen in real life situations where people encounter challenges. So the orange bar represents what we actually see in clinical practice. And as you can see, with a daily oral pill, we have a much higher risk of contraceptive failure. Even with injectables, we do see a higher risk of contraception failure because they have to return to clinic quarterly to receive the injection. And in this example, the only one that we don't have to worry about a change between perfect and typical use is implants. And that's because once it's there, and the user doesn't have to think about it, and it's not influenced by day-to-day occurrences. This data is also confirmed by a prospective cohort of about 7,500 contraceptive users. And you see here that implants and injectables worked very well. And then combining all other types of hormonal contraception, either by a pill or a vaginal ring or a transdermal patch, we see a higher rate of contraceptive failure. We hope that this will translate to our world of antiretroviral therapy, and our first opportunity for that is Kabbategravir rilpivirine, which I know you've already heard a lot about today. So here I just want to highlight what the PK looks like for Cab and rilpivirine over the 48 weeks of a combined Atlas and Flare analysis. And the key thing I'll highlight here is this is a logarithmic scale, so note that the actual change is much greater than it may appear here. But CAB has sort of a gentle rise in exposure with both of the products. They both achieve high concentrations above the protein-adjusted IC90 with the first dose. And then CAB will continue to accumulate, reaching steady state around 40 to 44 weeks after therapy. Rilpivirine, on the other hand, has a bit of a steeper incline and accumulation. And by the end of 1 year, it's only about 80% of steady state. So we still see some additional accumulation beyond that time. We have a preview of what the administration recommendations are going to be for Kabbategravir rilpivirine based on the Canadian label. And this looks very similar to what we saw in Atlas and Flare. So 1 month oral lead-in period, first loading dose with a higher dose of Cab and rilpivirine, and then monthly injections thereafter with a slightly lower dose of Cab and rilpivirine. We expect that maybe we'll see some changes with the data emerging from Atlas 2M, but these are the currently available recommendations. So with an oral product, we sort of know what a missed dose looks like, and we know how to advise our patients what to do about a missed dose. With long-acting therapy, we don't have these set rules, and it may depend on the type of long-acting therapy available. So based on the Atlas and Flare studies, they allowed a window of 7 days around the planned injection date. And typical to a phase 3 clinical trial of highly adherent study patients, most individuals fell within that 7-day window. We had very few occurrences of injections outside of that period. So we don't have a lot of real clinical data on what happens when the injection occurs outside of the 7-day period. But despite that, the 7-day window is what is presented in the product labeling. So within 7 days, you just give the injection as planned. After 7 days, you should plan to use an oral bridging therapy. Again, if you can plan for that through having an oral product available for a patient in case they have an unexpected trip or they're quarantining due to COVID, they have access to an oral product to bridge therapy until they come back. And then resumption of the injection is dependent on how long it's been since the last injection dose was given. And as Dr. Flexner showed you this morning, this is an example of the population PK modeling that was done to determine that dose, the dosing strategy. The only thing that I'll add here is that, as I described, there's an accumulation of drug product over time. So I think that a missed dose in those early weeks of therapy and those early months of therapy is probably going to be more clinically significant for some individuals than later in therapy. We also know from existing data from both Atlas and Flare, as well as the Kabbategravir HPTN prevention studies, that these are truly long-acting drugs. So even after the last injection, the products remain in some individuals up to a year and longer. But you'll see there's also wide variability, and it's hard for us to know at this point which individuals are going to fall below an effective threshold within a few weeks, or which are going to have effective concentrations for well over a year. So our most conservative strategy right now is to initiate an alternative oral antiretroviral regimen as soon as within the month after stopping injections. And I think this will be easily achievable for patients who are engaged in care because we don't expect there to be a lot of drug interactions that would prevent other antiretroviral combinations to be used after ceasing the injection. Where this is going to be harder is for those individuals who are not currently engaged in care or lost to follow-up. And we don't yet know when those patients are going to be at a period of risk for biologic failure and potential resistance. So I hope I've highlighted what we know or what's currently in available labeling and what we don't know about our understanding of how to manage adherence of these products. I think as Kabbategravir becomes available, we will start to see real-world data, so we'll understand more about the importance of that 7-day period of time, particularly as we move to potentially dosing every 2 months instead of every month. I think we need to learn more about which individuals are at greater risk for missed doses or delayed doses. And we'll have to think about logistically how we're going to offer patients an oral bridging therapy for those emergency circumstances, and how we're going to really track how patients are coming back or when they may have a delayed visit. And then I also will just mention, I think we're all looking forward to results from the Latitude study, which will give us some information about patients in the real world with some real adherence barriers and how this product performs. So with that, I'll now shift to the clinical management of drug-drug interactions. And I think our hope always with long-acting products is that we can avoid drug-drug interactions. It was certainly the hope in contraception. So I'm going to give you 2 examples. Here is a vaginally administered hormone that's given in combination with antiretroviral therapy. So you can see here the green bar represents the progestin exposure in the absence of an enzyme inducer or inhibitor. And I think it's pretty clear from this that when given in combination with an enzyme inhibitor or inducer that influence the hormone metabolism, we saw a significant change in exposure that was either similar to or even greater than what we see with oral hormone in combination with ART. And then we saw a similar story with a contraceptive implant plus enzyme-inducing antiretroviral therapy. So unfortunately, we don't avoid all of our drug interactions, but hopefully with the right product, we can manage them. So here's our Kabbategravir and rilpivirine potential for drug-drug interactions. In the first column, I've described the potential mechanisms for drug-drug interactions that will affect the exposure of antiretroviral therapy. So you'll see that both are metabolized in some way, Kabbategravir via glucuronidation by UGT1A1 primarily, and then rilpivirine, as we know from the oral product, is a substrate of CYP3A4, which is always a challenge for drug interactions. Both have some additional drug interactions related to oral absorption. And then in the final column, you'll see that I've described the potential for these antiretrovirals to affect co-administered medications. And the good news is that there seems to be fewer of these types of interactions. So focusing first on the mechanisms that could affect antiretroviral therapy, I want to remind you of our pharmacokinetic exposure. And this is an example of the trough concentrations from flare in relationship to the protein-adjusted IC50 for either Kabbategravir in green or rilpivirine in red. And just visually looking at this, you can see that we have a little less of a pharmacokinetic cushion for rilpivirine than we do with Kabbategravir. So I think drug interactions that decrease exposure to one of these products or both of these products, whether it's contraindicated or precautionary, is going to be driven by the effect on rilpivirine because of its proximity to the effective concentration. Some good news. So we know that INSTIs in general, and Kabbategravir is no exception, are chelated by polyvalent cations like calcium or iron or other antacids. So we do have to separate the oral lead-in period from any cation product. And then we know that oral rilpivirine not only requires food, but is also sensitive to acid suppressing agents and drug-drug interactions related to that. The good news with the injection, we're entirely avoiding the GI tract, so we can avoid all of these drug-drug interactions. So we have achieved our goal of simplifying some of those interactions. Okay, so when we think about metabolism-related drug interactions, we have to think about it a little differently for injectable products compared to oral products. So what I've described in this graph here is what we expect with a metabolism-related drug interaction with an oral product. So the solid line represents the exposure without the interaction. The triangles are with an enzyme inhibitor, which would slow down metabolism and prolong the half-life. And then you have the circles, which represent an enzyme inducer, which would increase the rate of metabolism and decrease the half-life and increase the elimination from the body. Long-acting antiretroviral products like rilpivirine have something called flip-flop pharmacokinetics. And what that means is that the elimination or the half-life of the drug is actually determined by the absorption of the drug from the depot site or the device that's administering it. So what you see here is that if you give it in combination with an enzyme inducer or inhibitor, we don't see a change in the slope of the elimination. You see sort of a shift up or a shift down, because although you are metabolizing the drug faster, the curve is more determined by how that drug is being absorbed from the injection site. So here is a list of the potentially significant drug-drug interactions for CAB and rilpivirine. I'll first highlight that we don't have any current drug-drug interaction studies with the injectable form of either CAB or rilpivirine. So as you'll see here, all of the data that informs our understanding of this is either theoretical based on known metabolism of the products and co-administered medications, or it's extrapolated from an oral drug-drug interaction study through either direct extrapolation or modeling of that interaction. So based on that information, it's probably not surprising that the contraindicated medications are all related to drugs that induce the metabolism of one or both of the products via cytochrome P450 or glucuronidation, resulting in lower exposure and potentially reduced effect. So the first rule of thumb is always check for any enzyme inducers when you're combining or starting injectable therapy. Our more amber warnings are more related to either increased exposure or effects of rilpivirine on the co-administered medication. So I just want to give you an example of that flip-flop pharmacokinetics and how the oral information has been extrapolated into the injectable formulation. So here's a typical clinical pharmacokinetic study of a single dose of oral Kabbategravir given alone in the teal line. And then after about 21 days of rifampin in the purple line, again as a single dose. So you see here again, you see a more rapid clearance of Kabbategravir related to the increased metabolism and a shorter half-life. We've been able to use physiologic-based PK modeling to take that information and inform what we believe will happen with an injectable Kabbategravir in combination with rifampin. And as you see, you'll still see a similar decrease in the area under the curve, although perhaps a little less. And again, you see just that shift down of the curve rather than a more rapid elimination of the drug. Irrespective, both of these result in a contraindication of a potent enzyme inducer in combination with these products. So just a quick look back onto our final concern of the effect of Kabbategravir and rilpivirine as a perpetrator of drug-drug interactions. Again, as I've described on the first slide, we don't think that there's going to be a lot of metabolism-related interactions. Rilpivirine at super therapeutic dosing does have some induction of some enzymes, but it's not expected to occur at either oral or injectable dosing. But again, I'll highlight we don't have any current data with that. There are some cautions related to the interaction based on drug transporters, specifically via inhibition of OAT13. So drugs with a narrow therapeutic index that are substrates for that transporter may be used with caution. I will note that this Kabbategravir is different than Bictegravir and dolutegravir in that it does not seem to inhibit OCT2, so we don't expect to have the same interaction with metformin that we see with our earlier instis. And then the final thing I'll highlight is that we know that rilpivirine does have potential to be associated with QT prolongation. So we want to avoid co-administration of other QT prolonging medications when possible. The thing I'll note here is that this is likely to persist for up to a year or longer after the drug is discontinued. So this will pose some challenges for typical drug interaction screening, as the patient may no longer be on therapy, but still have this persistent risk. So I hope I've highlighted some of the gaps of our understanding related to drug-drug interactions to date. I think we've been able to do amazing things with physiologic-based PK modeling to understand what we expect with drug interactions. But as a clinician, I look forward to also having some clinical pharmacokinetic data to really inform these interactions. I think we also need to better understand the potential mechanisms of interactions with not only injectable, but other long-acting products. And as I mentioned before, we need to understand which individuals are going to be at greater risk for potential drug interactions and detrimental drug interactions when combined. So thanks for listening to my thoughts on some of the issues that will face us in the clinical management of both adherence and drug-drug interactions. I really think once these drugs are used in the real world, we'll understand much more about this in the future. In the meantime, particularly for drug interactions, I'm going to be relying on the Liverpool website and other up-to-date drug-drug interaction sites in order to really keep up to date on this really rapidly evolving topic. So with that, I will close and I will thank you for your attention, and I'll thank Dr. Flexner for sharing his slides from earlier today so that I could hopefully build upon his prior discussion. Thanks very much.